Breast Cancer, presented by Dr. Aaron Shavinsky, Director of Surgical Oncology at Aurora Healthcare, Aurora St. Luke's Medical Center in Milwaukee, Wisconsin. Please give a warm welcome to Dr. Shavinsky.
Good morning, everybody. Hopefully you're having a good week. I have you for the morning sessions on breast, liver, pancreas, and some general topics in surgical oncology. So the purpose of today's lecture is not to teach everybody how to do breast surgery, or particularly not for the breast surgeons in the room. This is really to help those people who don't do breast surgery that often get through some of the questions, because more than any other lecture that I give for this course and for others, this topic changes the most every year. And in fact, I was updating the slides up until a time a month ago when I had to submit the final thing, and there are things that have changed since then. So I will try and give you what I consider to be the middle of the road approach. Obviously, there are questions, and there's very little agreement in a lot of things in breast cancer, and things change very quickly. So I just try to give you what I think is the standard safe answers, understanding that different things get done differently in different places. So these are my disclosures. I'm not going to be discussing anything of which I need to disclose, other than I'm on the Speakers Bureau of Genomic Health, but we'll talk a little bit about genomics, but not about that product. Our module today, and this lecture lasts about an hour and 3/4, roughly. We're going to go straight through and then take a break after that and for questions. We're going to talk about demographics, who gets breast cancer, what are the risk factors, how do you screen for breast cancer, and what are the new guidelines, and what are the new guidelines, and what are the new guidelines which have changed over the past few years. How do you image the breast, what types of biopsies are available, and how do you choose? How do you manage patients at higher risk for breast cancer, management of both invasive and in situ cancer, treatment, management of inflammatory and advanced breast cancers, and then end up talking about genetic screening. We'll also touch a little bit about the management of benign breast diseases as well, and those that are at risk but are benign yet. So, this is our first question. Which of the following statements is true regarding breast cancer? Breast cancer is the leading cause of cancer death in women. Breast cancer accounts for 1/4 of all new cancers developing in women. Male breast cancer accounts for approximately 5% of all breast cancer in the U.S. African American women have a better prognosis than Caucasian women when they develop breast cancer, or women diagnosed with breast cancer in 2013, or for that matter 2016, have a predicted 5-year survival of 70%. So if you want to go ahead and answer. Okay. And the correct answer is B. Breast cancer accounts for 1/4 of all new cancers in women. Breast cancer is the second leading cause of cancer deaths in women. The first is lung cancer. Male breast cancer accounts for 1% of all breast cancers in the U.S., and the survival rate for breast cancer, all comers, 5-year survival is 90%. So, a few words about demographics. Roughly 234,000 new breast cancer cases in 2015, 40,300 deaths, 15% of all cancer deaths in women. It's the number 1 site of new cancers in women, but the number 2 site of cancer deaths, number 1 being lung cancer, and it represents 1/4 of all new cancers that develop in women. Women diagnosed with breast cancer this year and in 2013 have a roughly 90% chance of being cured in quotation marks, because you can say that nobody is ever really cured of breast cancer. Particularly ER-positive breast cancer can come back 10, 15, even 20 years without any antecedent history and without any changes. We've seen women come back 15, 20 years later with recurrent breast cancer, either distant or in the same location. The risk of developing breast cancer in the United States, birth to death is 1 in 8 women, or roughly 12.5%. 12.5% of all women in the United States will develop breast cancer at some point in their life. And if we look at the incidence and death rate of breast cancer, we can see that incidence of breast cancer dropped 7% when the wholesale use of postmenopausal estrogen therapy stopped. And we saw that change about 10 years after that, and the mortality rate has decreased due to improvement in screening and in treatment. So, what's the lifetime probability of developing cancer in the United States if you're a woman? And that's 1 in 3. So 1 in 3 women in the U.S. will develop cancer, excluding skin cancer and superficial bladder cancer in their life. If you're a man, the numbers are even better. It's 1 in 2. So 50% of all men in the U.S. will develop cancer in their lifetime. And you can see the risk of breast cancer is 1 in 8. As far as ethnicity in breast cancer, white women in the United States have the highest incidence of breast cancer compared to African American women or Hispanic women, whereas African American women die more commonly of their breast cancer than do white or Hispanic women. 90% of white women survive 5 years after breast cancer diagnosis, compared to 78% of African American women, and that's in part due to a higher risk of triple negative ERPR and HER2 negative breast cancer in African American women. Also, something to do with demographics, access to care, and screening as well. And the 5-year survival for breast cancer over the past 40 years, we can see that breast cancer has improved roughly 15%, 5-year survival from the 1970s through the 80s and up till today, and all cancer mortality, false alarm, all cancer mortality has improved about 15% over that same time period. So that mirrors the improvement in breast cancer survival as well. So we're going to move on to talking about the risk factors for breast cancer. So this, our next question is, which of the following increases a woman's chance of developing breast cancer? Therapeutic radiation to the chest for Hodgkin's disease as a teenager, the presence of cosmetic silicone breast implants, multiparity, the use of oral contraceptives for 6 months at the age of 18, or having a mother-in-law with premenopausal breast cancer. And the answer is A, therapeutic radiation to the chest for Hodgkin's disease as a teenager. D, we'll talk about the use of oral contraceptives. And E, whoever chose E didn't read the question. Because I don't believe that your mother-in-law's risk to your life may be different, but to your breast cancer is something else. So these are the known risk factors or thought to be risk factors for breast cancer. I divided them up into patient-dependent and patient-independent. So the patient-independent factors include female sex. Women get 99% of all breast cancers in the U.S. Male breast cancer is approximately 1%. The early onset of menstrual periods before the age of 12, or the delayed menopause after age 50. Previous breast cancer, and again, when I say 5 times the risk, it's relative risk, not absolute. So you don't take, your risk is 12.5%, you multiply that by 5, and if you have previous breast cancer, your risk is 60%. This is a relative risk increase over the general population. Family history of breast cancer increases your risk from 2 to 6 times, depending on whether it's a first-degree relative, whether they developed the breast cancer at an early age, presumably premenopausal, whether they had bilateral breast cancer, or whether they carried the BRCA gene mutation, which we'll talk about toward the end. But also remember, and very importantly to teach the residents and the students, that 80% of women have no or only a remote family history of breast cancer. So while family history is important, 80% of women will not have a close family history of breast cancer. High breast density alone on mammography increases your risk. Atypia on a breast biopsy, that is atypical ductal or atypical lobular hyperplasia, increases your risk roughly 4 times. And if you have both a strong family history and atypia, then you've hit the breast cancer lotto, and your risk is the highest of the known risk factors. A history of endometrial or ovarian cancer also increases your risk somewhat. Now, the patient-dependent risks of breast cancer, if you're nulliparous, your risk is 30% increased over the general population. If you're delayed first pregnancy until after age 30, increases your risk. The use of DES, diethylstilbestrol, in the pregnancy in which you were conceived increases your risk. Prior radiation therapy including the area of the breast, roughly triples your risk of breast cancer. And this is particularly important for teenage girls, adolescents and teenage girls who received radiation for things like Hodgkin's disease during their teenage years. The risk is not realized for approximately 20 to 30 years. So girls who were radiated in their teens will come down with or develop breast cancer in their 30s and 40s, and it's a double hit because since they've been previously radiated, many cases they're not candidates for breast conservation, because in order to do breast conservation you need to have radiation therapy backup, and you can't re-radiate if they've been radiated again, even if it was done in the past. That's not absolutely true. And by the way, just to make it clear, nothing I say is absolutely true. And it will all change by tomorrow. But it's generally true. And we'll talk about that as we go along. The use of hormone replacement therapy for more than 5 years increases a woman's risk about 2% per year, and it doesn't matter if it's bioidentical hormones or whatever type of hormone replacement is used. Multiple prior breast biopsies, as the increase in risk of breast density, increasing breast density, they kind of go together, as many women who have a lot of things going on in their breast will have multiple biopsies, will also have a higher risk of breast cancer. A sedentary lifestyle or physical inactivity, obesity, a high-fat diet, or more than 2 alcoholic drinks per day also increase the risk. These are the best that I was able to come up with, and of course they change a bit time to time. Other factors that people have brought up: the use of oral contraceptives in general does not increase your risk of breast cancer, and in fact is somewhat protective for ovarian cancer. However, if somebody is 45 or 48 and using oral contraceptives, chances are they're not using it for contraception, but as a surrogate for hormone replacement. And in that regard, that may increase the risk. The use of pregnancy induction hormones for IVF, generally speaking, does not seem to increase the risk. The only exception to that is Clomid or clomiphene, which slightly increases the risk. Some things that go around the internet from time to time include the use of antiperspirants, particularly those with aluminum. That's never been shown to increase breast cancer risk. The use of mammography or X-ray, short of X-ray therapy, radiation therapy, doesn't seem to increase the risk. And in fact, the risk, you get about 1 chest X-ray's dose of radiation flying from New York to Los Angeles. And flight attendants have never been demonstrated to have an increased risk of breast cancer. interestingly enough, they do have an increased risk of melanoma and skin cancer due to the exposure to the radiation. Cosmetic breast implants don't increase the risk of breast cancer, but silicone breast implants do seem to increase slightly the risk of some types of non-Hodgkin's lymphoma. And there are certain types of lymphoma that are similar to the malt lymphomas of the stomach that women can develop with long-standing silicone breast implants. Breast trauma does not increase the risk as well. And things that can reduce your risk of breast cancer, theoretically, including having your first child before the age of 18, because your parents will kill you. Though, as I'm sure many of us are parents in the room. But that does seem to reduce the risk. Early oophorectomy before age 35 if you don't go on hormone replacement. Breastfeeding does slightly reduce the risk. Maintaining a healthy weight and being physically active can reduce your breast cancer risk up to about a third. And a low-fat diet, as well as reducing alcohol intake, also seems to reduce the risk. All right, moving on to screening. Next question. All of the following were part of the screening guidelines recommended by the U.S. Preventative Services Task Force, U.S. PSTF, in November of 2009, except no routine screening with mammography between ages 40 and 49, biennial or every other year screening for women 50 to 74, ultrasound screening for women 40 to 50, no screening for women 75 years or older, and no teaching of self-breast exam. So which of the following, which of these was not in those recommendations? The hint is 4 out of the 5 were in fact in those recommendations. All right, so the correct answer is C. Probably no area in breast cancer treatment other than the evaluation of margin status has had more changes over the past 5 years than screening guidelines. And nobody agrees with all of the screening guidelines. And each society, the ASBS, the Radiologic Society, the American Cancer Society, all have variant guidelines, but I will try and go through what's generally accepted, and then we can go from there. So, all of the others were in fact in the USPTF guidelines, which were the first to change the American Cancer Society guidelines, which had been sacrosanct for many years. So they recommended no routine screening between 40 and 49, every other year screening between 50 and 74, no screening after 75, and no teaching of breast self-exam. This came out in 2009 with the rolling out of the new health care plan and the Affordable Care Act, and this was the first salvo into trying to change well-entrenched guidelines, which was met with just a cacophony of objection from every society and every women's group, Susan G. Komen and the American Cancer Society. But as it turned out, many of those societies have recanted based on evidence-based guidelines, and we'll talk about some of the newer guidelines as we go along. But this is really still a hotbed area of controversy, and if you ask the radiologists, they'll give you a completely different answer than if you ask, for example, the surgeons or family practitioners. And remember that the USPTF, which you'll see coming out with guidelines for prostate and for colorectal cancer, is a group that's made only of primary care physicians, no surgeons, no pathologists, no radiologists, no oncologists, just primary care physicians. So, what are the current best recommendations? This is from the American Cancer Society. Breast self-exam is no longer recommended. That was rescinded in November of 2015. The feeling was that there has never been any study that showed breast self-exam either improved survival, reduced mortality, or increased diagnosis risk. Clinical breast exam which used to be recommended every year, was rescinded also in November of 2015 and is also no longer recommended. So you no longer have to tell women to examine their own breasts, and primary care physicians are no longer required to do breast exams to look for breast cancer, because it was not felt to increase diagnosis, reduce mortality, or increase in improvement in survival. Mammography. Currently, the annual mammography should be done between ages 45 and 54, with biennial screening after age 55. Again, all of these apply to average risk women. Women with a family history or a prior history of cancer, women who are at higher risk, these guidelines do not apply, and the prior guidelines are still the ones that are followed. So this is just women of average risk with no increased risk guideline. MRI screening annually for women at highest risk, and this is the one that has the most controversy of all, is how do you define what's higher risk? But their definition is somebody who has roughly twice the risk of breast cancer as the general population by any one of the different formulations and risk calculators, the most common of which is the Gale model. And there's no upper age limit on screening. This is for the American Cancer Society guidelines, which is in general what most breast centers and most people follow. The U.S. Preventive Services Task Force, their initial recommendations came out in November of 2009, were updated just about a year ago. No routine screening for women between ages 40 to 49 for women of average risk. Biennial screening, 50 to 74. No screening after 75. No teaching of breast self-exam. The evidence for clinical breast exam was equivocal, and digital mammography, tomosynthesis, which is 3D mammography, and MRI evidence was equivocal as well. Now, there is, I don't believe, hardly any breast center in the United States that's doing any volume of breast screening that hasn't converted over to digital mammography. And the difference, for those who are unaware, between digital mammography and film screen mammography is that it's the difference between a Polaroid photo, for those of you who are old enough to know what a Polaroid is, and a digital photo. A Polaroid photo is one shot, everybody looks at the same shot, whereas a digital photo is done and stored on computer where you can manipulate the image, you can have special algorithms to read it, you can look at and have the computer pick out areas of concern, you can blow up an area, you can invert the image. So almost everybody has converted over to digital mammography by today, and many breast centers are now using tomosynthesis or 3D mammography, which is essentially looking like a CAT scan of the breast, where you're doing it slice by slice imaging. And most breast centers, at least those in bigger cities and doing higher volumes, are already using tomosynthesis pretty routinely, particularly for women at high risk or with dense breasts or to help solve the problem. The reason for this was that there were many false negative mammographies, which then led to further evaluation with additional imaging, and many biopsies which turned out to be benign. And this is in a way to try to reduce that risk and reduce the callback rate and improve the risks of biopsy, so that you're not worrying a lot of women unnecessarily and doing a lot of unnecessary biopsies. So, some other recommendations. The USPTF found adequate evidence that screening for breast cancer with mammography results in harm for women ages 40 to 74. The most important harm is the diagnosis and treatment of non-invasive and invasive breast cancer that would otherwise not have become a threat to the woman's life or even apparent during her lifetime. Now, I have a hard time believing this. This is a direct quote. You can take it for what it's worth, but it is out there. False positive tests are common and result in unnecessary and sometimes invasive follow-up testing with the potential for psychological harm such as anxiety. False negative tests, i.e. missed cancers, also occur and provide false reassurance. And radiation-induced breast cancer and resulting death can also occur, although the number is predicted to be low. Again, not my opinion, but this is out there. These are direct quotes from the United States Public Service Task Force. You ought to know what's out there and what patients are reading. Women with dense breast and an otherwise negative mammogram, ultrasound, or MRI will detect additional breast cancers, but will also result in a higher number of false positive rates. Women with dense breast or an otherwise negative mammogram who have ultrasound or MRI will detect additional breast cancers. Data on tomosynthesis in women with dense breast is limited, but it appears to detect additional breast cancers as well. These cancers may fall into one of three categories: those for which earlier detection leads to improved outcome, those that would have had the same outcome when detected later, or those that are overdiagnosed and the data is still unavailable. Most positive adjunctive breast cancer screening tests are false positives. Compared with mammography alone, adjunctive screening with ultrasound or MRI appears to increase recall and biopsy rate. So that's where the morass still sits without any clear guideline regarding these new technologies. Still, if you look at how many women in the U.S. actually get mammography, about 2/3. If they have less than a high school education, about half. And if they have no health insurance, about 1/3. But of course, everybody now has insurance, right? Of course they do where I am. Okay, moving on to breast imaging. So, question. All of the following radiologic factors are suspicious for breast cancer except clustered pleomorphic microcalcifications, a mass which is taller than wider on ultrasound, milk of calcium type of microcalcification, an MRI with an irregular mass and type 3 contrast enhancement, and a new spiculated mass on mammography. So which of the following is not suspicious? And the answer is C, milk of calcium type. Just remember that any time you see something that's either irregular or spiculated, it's never good. Just on the exam, anything that they say is irregular or spiculated, that's going to be the cancer in general. Milk of calcium type of microcalcifications are associated with fibrocystic disease, and the pathognomonic finding on ultrasound is a mass that's taller rather than wider, and that's pathognomonic for breast cancer. So mammography is an X-ray picture of the breast taken in at least 2 projections. Abnormalities seen may indicate malignant changes months or years prior to feeling a lump. Two-thirds of American women get routine mammography. And we're looking for things such as microcalcifications, masses, areas of architectural distortion, or skin and nipple changes. And the typical mammography that we grew up with, it was a film screen mammogram. That has by and large been supplanted by digital mammography, moving now towards tomosynthesis or 3D mammography. Screening mammography is used for women who have no breast symptoms or signs of cancer, and there have been recent questions on the exam about the difference between screening mammography and diagnostic mammography. So I would just make a note of this particular page, this slide, because that has come up on recent exams. Remember that a screening mammogram is done in somebody without a symptom, without a history, and doesn't necessarily have to have a radiologist on site for on-site interpretation. That can be centrally read or read at another location, and doesn't have to have a radiologist there. It's typically 2 views, the CC or craniocaudal and the MLO, a medial-lateral oblique view of each breast. A diagnostic mammography is anything that's not a screening mammogram. A finding, a symptom, family history, prior biopsy, prior cancer. It's for evaluation of a current problem or women with prior history of breast abnormality or cancer. Images are reviewed on site by the radiologist while they are there, so that more pictures can be taken if needed to look more closely at an area of concern. So the real difference is in who gets recommended for each, and the fact that the radiologist is on site for a diagnostic mammogram to review the image contemporaneously and can then recommend additional views if necessary. And this has come up on a prior exam, so just remember that. So here's our typical view. On the upper left is the film screen. On the upper right is the digital. And then below that are just images of a 3D mammogram and how they're presented. So the first one is actual hard films that you actually put up on a view box. All of the others are available electronically and digitally to review. And what are we looking for? Well, if you look very closely at that area, you can see an area of microcalcifications. Microcalcifications are irregular, pleomorphic, and a cluster is defined as 4 or more calcifications within a centimeter. That's the definition of a cluster. So 4 or more calcifications in an area under a centimeter is a cluster. In general, abnormal pleomorphic microcalcifications will have a cancer risk of roughly 20%. 1 in 5 biopsies will be positive. And if they go down a ductal pattern, the more calcifications there are, the more irregular they are, the worse the chance of that happening, whereas things like this, which are single, large, and round, are not considered particularly suspicious. That's a macrocalcification as opposed to these, which are microcalcifications. And of course, if you see something like this, there's very little chance that it could be anything other than a breast cancer, with the exception of perhaps a biopsied area that's been radiated or an area of fat necrosis. But if somebody has not had prior surgery or radiation and you see this, this is a breast cancer. It's a sine qua non. They're spiculated, they're retractile, they have little spokes radiating out from them. They retract the skin, they pull down the skin in the nipple, and if you see something like this on the exam, it's breast cancer until proven otherwise, often will be palpable. Ultrasound is an adjunct to mammography, particularly for use in young or pregnant women or women with dense breasts. It can help differentiate cysts from solid masses, can find tumors missed on mammography, and can be used to guide biopsies and aspirations. It can be done in the physician's office with little preparation and very little discomfort. So, what's benign and what's malignant on an ultrasound? Benign lesions on an ultrasound are round or oval with a crisp border and an equal echo texture. Period. Anything that is not that, you have to be suspicious of. So round or oval, crisp border, equal echo texture inside. If they're oriented transversely, that tends to be benign. If they're oriented vertically, meaning that they're taller rather than wider, that's suspicious. And these are all pictures of breast cancer. You can see they're irregular. The margin's irregular. The echo texture on the inside is not regular, and they're taller than wider. Typically, if it's perfectly black inside, that usually represents a cyst. If they're perfectly white, that's a soft tissue mass like a fibroadenoma. If they have mixed echo texture, it could be a complex cyst. And complex cysts are mostly benign, but have a slight risk of malignancy. And when you drain them, the fluid can be green, it can be slightly tan, yellow. If it's bloody, you have to be a little concerned about it unless it was a traumatic tap. MRI is a newer technology which evaluates the breast with magnetic waves rather than X-rays, differentiates fibrocystic lumps from cancer, determines the extent of cancer within the breast, and can be used for treatment planning to see the extent of cancer within the breast to see if a patient might be a candidate for lumpectomy or mastectomy. It's useful in evaluating cosmetic silicone breast implants for implant rupture. can identify abnormalities that can be missed on mammography, ultrasound, or clinical exam, and should not be used in screening of average risk women based on the choosing widely recommendations that were a joint recommendation of the Society of Surgical Oncology, the American Board of Internal Medicine, and the American Society of Breast Surgery. That's a recent recommendation that that MRI should not be used as a screening tool in average risk women. Indications for breast MRI, very difficult because not all insurance companies will pay for all indications, but generally speaking, a BRCA1 or BRCA2 mutation carrier, an untested first-degree relative of a BRCA mutation carrier, or anyone with a doubled lifetime risk by any model that increases your risk of breast cancer about twice that of the baseline. Based primarily on family history and a clinical history associated with a significant risk for breast cancer. Expert consensus-based include women who have had chest irradiation between the ages of 10 and 30, or those with other syndromes other than BRCA, which can be associated with breast cancer, which include Li-Fraumeni, Cowden syndrome, and Banyan-Riley-Rubalcaba syndrome, which also are genetic syndromes increasing the risk of breast cancer. We'll talk about that toward the end as well. And no clear consensus. A family history of breast cancer, a lifetime risk that's intermediate, i.e. 1.5 times baseline. Patients with either lobular carcinoma in situ or atypical hyperplasia, just a dense mammogram, or just a prior personal history of breast cancer. There's no clear consensus about the use of MRI. Now remember that MRI for breast cancer is always done with gadolinium, prone, and with both breasts screened. So therefore, they generate several hundred images for each breast. And here you can see, this is the left, L, right, R, normal, abnormal, normal, abnormal, normal, abnormal, all the same person. This is a patient with DCIS involving many of the ducts throughout the breast, and it's not surprising that this person would not be a good candidate for breast conservation given the extent of the DCIS within the breast. There's a lot of controversy about when MRI is appropriate and when it's not, which we'll talk about in a minute. So, when you have a breast MRI, it will be reported by kinetics. You'll say there's a lesion in the breast that has type 1 kinetics or type 2 kinetics or type 3 kinetics. Type 1 is where the contrast that goes in has a slow and continued rise with time. And a lesion with a type 1 curve has about a 6% malignancy rate. Whereas type 3, you have a rapid initial rise and then a drop-off. And those are the most suspicious. And those with a type 3 enhancement have a risk of breast cancer of 60 to 80% roughly. And type 2 is somewhere in between. So generally speaking, type 1 kinetic lesions you generally watch. Type 2 and type 3 you generally would recommend for a biopsy. It's all clear like Lake Erie, right? So, a couple of articles and some information. Does preoperative breast MRI increase the risk of having a mastectomy? This was something that's still very controversial. So here are two studies. The first is the Mayo Clinic study, 1997 to 2006 of 5,400 patients. They noted that mastectomy rates increased from 31 to 43% during the time of the study, particularly during the last part of the study. And MRI rates similarly increased during that time. But the largest rise in mastectomy was in the non-MRI patients, based on that study. The Moffitt study showed mastectomy rates increased from 33 to 44% during that same time, with the reasons being informed patients, fear of the risk of radiation, availability of better reconstructive options, cultural differences, desire for more aggressive treatment, particularly in younger women, and more aggressive histologic or biologic tumors. But there is no question that there has been an increased rate of mastectomy in the younger patients that we see for breast cancer from multiple different reasons. But it's clear. So what are the reasons to get a pre-surgery MRI? Well, you can detect additional cancers, 16% in the same quadrant, 5 to 10% in other quadrants. You can detect contralateral cancers. You can more accurately stage the patient. You can look for the extent of disease, particularly in lobular cancer. Intraductal extension. Studies are mixed on whether you get a better re-excision negative margin rate. You can evaluate the axilla. You can look for occult breast cancers in patients presenting with only axillary nodal disease, and in 10 to 20%, it can affect the preoperative surgical plan. Why would you not get a pre-surgical MRI? This article written by Monica Morrow, who is one of the breast cancer leaders in this country and is vehemently anti-MRI. So her reasons are that it delays treatment. The average time to surgery from diagnosis is about 3 weeks in women who do get an MRI. I'd venture to say that it's probably the same in women who don't get an MRI because they're going for second, third, fourth, and fifth opinions. But at least in this group it was. There's an increase in mastectomy rate. There's no clear improvement in margin status. There's been no determined improvement in long-term survival or reduction in recurrence. There's cost, anxiety. It finds more contralateral cancer than are routinely seen on follow-up and therefore may not require treatment, and most MRI findings are not malignant. So there is no clear consensus about whether you should or should not do an MRI in a patient with a diagnosed breast cancer. It's sort of like religion. Either you believe it or you don't. And you're either going to fall into one camp or the other. The jury is still out. Probably won't have the answer for about 5 to 10 years. Moving on to talking about breast biopsies. So, which of the following would be the most appropriate way to make a diagnosis in a woman found to have clustered microcalcifications on screening mammography? Ultrasound-guided core biopsy, needle localization and excision, MRI-guided core biopsy, wide lumpectomy, or stereotactic breast biopsy. And the answer is stereotactic breast biopsy. Generally speaking, you can't do an ultrasound core on calcifications because you won't see them. And a needle localization is the answer only if the radiologist is unable to perform a stereo breast biopsy, or the surgeon, whoever happens to be doing it in your community. So, what are the available techniques for biopsy of breast cancer? Starting with the simplest FNA, or fine needle aspiration, core biopsy, stereo biopsy, needle localization and excision, incisional and excisional biopsy. And we'll touch on these. So FNA is the simplest and easiest to do, where you put a needle into a lesion, draw fluid out or draw out cells, put them on a slide, stain them, and send it to your cytopathologist, who will then in 24 or 48 hours give you an answer. That answer will be benign, atypical, highly atypical, suspicious, malignant, or in about 20% of the cases, not enough cells to make a diagnosis or non-diagnostic. This is useful in people who you are pretty sure have cancer, or you're pretty sure don't have cancer. For example, if you're draining a cyst and you want to send that fluid off. Generally speaking, most everything else will be determined on core biopsy. So if you're pretty sure this is a cancer, or you're pretty sure it's not, an FNA may be helpful, but most biopsies are done on solid lesions, at least, using core biopsy technology. And that's these. And you have any one of a number of different sizes and shapes and types of core biopsy. There are a number of ways that core biopsies can be done. They can be done freehand if you have a palpable mass. They can be done under ultrasound. They can be done under MRI. They can be done under mammography, which is called a stereobiopsy. And if you look at in the vast world of breast diagnostics, I would venture to say that probably 60 to 70% of all biopsies are done under ultrasound guidance. About 30% are done under mammography guidance, and about 10% are done with MRI, roughly. So most of the time, the workhorse is the ultrasound. So you get a large core specimen. The pathology is equivalent to an open biopsy. You can get hormone receptor and marker studies, including ER, PR, and HER2, but you also have to be recognize that there can be sampling error. And I want to introduce the concept now of concordant and discordant biopsy, which is very important. So a concordant biopsy means that you've answered the question that you've posed to the person that's doing the biopsy. What is this lump? And a concordant biopsy gives you a diagnosis, cancerous or not, but it gives you a histologic, pathologic diagnosis that answers your question. A discordant biopsy does not answer your question. You have a person with a spiculated mass, you send for a core biopsy, the core biopsy comes back normal breast tissue. That's a discordant biopsy. That doesn't answer the question, what's this lump? And you need to go further in doing additional biopsies or additional treatment. On the other hand, if you get back fat necrosis, pseudoangioma stromal hyperplasia, dense fibrocystic disease, that might or might not be concordant based on what you think the lesion is. So always remember that when you're sending somebody for a biopsy or doing a biopsy yourself, you have to think in your mind, what's going to satisfy me that this is a diagnostic procedure that answers the question that I sent that patient for. Many, many lawsuits have been filed because of the fact that a biopsy is done and accepted on FOSS as being true when the lesion was never sampled adequately. So always make sure when you look at those biopsies, does this answer the question for which I sent that patient to get a biopsy for? Very, very important. So stereobiopsy is a mammographically directed large core vacuum assisted biopsy done only for lesions seen on mammography. So stereotactic biopsies are only done for things that you see on mammography, be it microcalcifications, areas of scarring or spiculation or a mass. It's only done for things that you see on mammography. And they're outpatient procedures. They're done under local anesthesia. And you can see here our patient is prone. She's awake. This is done under local. This is a mammography unit back here. It swings around the patient in an arc of 180 degrees to approach the breast from either direction. So this is some new breaking, these not new anymore, breaking news from the COC-ACIP, the Commission on Cancer of the American College of Surgeons. Do not perform surgery to remove a lump for suspicious finding unless a needle biopsy cannot be performed. Core, stereo, FNA, etc. Knowledge of a positive biopsy reduces the number of procedures performed, improves cosmetic outcome, and improves margin status on excision. It's cost effective, eliminates the need for open biopsies in most cases. However, open biopsy is still needed in about 10 to 15% of cases. So why would you need to do an open biopsy? Well, if you have an area of microcalcification, there are limitations to stereobiopsies. Lesions that are too close to the chest wall or too close to the nipple or in women who are over 350 pounds, women who cannot lay flat for about 45 minutes because of back issues, psychiatric issues, or other things, are not candidates for stereobiopsy. So you will still end up doing a certain number of needle-localized biopsies for abnormal lesions in women who are not candidates for some of the minimally invasive biopsies. But that should be only about 10 or 15% or less. Yes?
If you have a discordant result based on a biopsy that was done, and you then look at a post-biopsy picture, and you see a marking clip place that is in the area of where the concern was, would that not satisfy the discordance?
Well, what's discordant about it? If you're doing something for microcalcifications and you don't see microcalcifications in the specimen, that's discordant. You need to rebiopsy that patient, either surgically or otherwise. If you biopsy an area that comes back normal breast tissue for a solid nodule, and you see the clip is within the nodule, that wouldn't make me sleep well. And I'd probably surgically go in and remove that nodule just to be sure. So I think it's a personal thing. I think there are levels of concordance and levels of discordance. I don't know if that answers the question. So needle localization and excision is the follow-up to a core or stereobiopsy, either if you have a discordant biopsy or if you have a cancer or precancerous lesion which needs to be completely excised. This is where the radiologist localizes the area with a hook and with a wire or a wire and a needle. Some people are now doing seed localization with a radioactive seed, which is also now becoming more popular. The surgeon removes the area and then does an X-ray specimen to confirm that they've removed the area of concern. And that's very important. Always remember to do your specimen radiograph either yourself or have the radiologist do it, and don't leave the operating room until you're sure that you've removed the target lesion. It's an alternative when a stereobiopsy is not possible, or to remove a previously biopsied lesion for which there's still concern. A word or two about benign breast masses. We're not going to spend a lot of time. The most common benign breast mass in young women is a fibroadenoma. In older women, it's going to be a breast cyst. And there are times in which you may need to be called upon to biopsy these if there's any insecurity on the diagnosis, or if they're growing or changing, or if there are any concerns that it might be malignant. Breast infections, the only time a woman is allowed to have an infection of her breast is when she's breastfeeding. Any other time, with the exception if they say I have a spider land on my breast and bite me, is alwaast suspicious for something else. So women who come in with breast infections that are not in the breastfeeding or intrapartum status, you always have to be concerned that there may be an underlying malignancy, and you always need to work them up for that. Fat necrosis is an area of damaged breast tissue due to trauma or radiation, which may feel hard and look suspicious on a mammogram and ultrasound, and over time it calcifies and forms oil cysts and other things. Mondor's disease, if that should come up, is superficial thrombophlebitis of the breast. Presents with abrupt onset of pain and swelling, redness, and the feeling of a firm cord. It's self-limiting and treated with warm soaks and nonsteroidals. Breast abscess is most common during breastfeeding, treated with antibiotics and warm soaks, and it may progress on from mastitis to a breast abscess, and ultimately may need for the woman to cease breastfeeding if it becomes severe enough. Galactocele is a retention of milk in a cyst after lactation, usually due to a protein plug in the duct, and it's treated usually by aspiration and antibiotics as necessary. A few words about breast nipple discharge or nipple drainage. History is important, whether it's unilateral or bilateral, whether it was during stimulation or not, whether the patient obviously is pregnant, breastfeeding. And you want to look at the color, the quantity, and the amount, as well as the quality. Is it cloudy? Is it bleeding? If you have a cloudy white color, particularly if it's bilateral, you want to make sure you check a prolactin level, because a prolactin secreting or a pituitary tumor which blocks prolactin inhibitory factor, a microadenoma of the pituitary will often present with bilateral galactorrhea. You can have a normal, clear or light white discharge in pregnancy, but if it's bloody in the absence of trauma, you want to be concerned about possibly an intraductal papilloma or a cancer. In some places, you can still get galactograms or ductograms. Most of the time, that's been supplanted by the use of 3D mammography, high-frequency ultrasound, and MRI. And if the drainage is whitish yellow, yellow, or green, you want to consider that a potential breast infection. The diagnosis and treatment, you want to do a metabolic evaluation, prolactin levels, thyroid functions, mammogram, ultrasound, possible ductogram. You want to do cytology on the nipple drainage. And if you feel that this is not a systemic problem, then you want to do a major duct excision depending on the age of the patient and whether they're planning on having children and wanting to breastfeed, which can either be limited to a single duct if you can identify the duct, or a major duct excision where you do a periareolar incision, ligate the duct behind the nipple, and do a biopsy of the tissue right behind it. If you see a lesion in a duct, you can do a needle-localized, ultrasound-guided excision of that area as well. Phyllodes tumors may be benign, borderline, or malignant. They're connective tissue or stromal tumors. They're not tumors of the ductal cells. They spread hematogenously. They're most common in the 3rd and 4th decades of life, and the treatment is for surgical excision with clear margin, mastectomy in cases where the tumor is malignant or not excisable to clear margin. Recurrences may occur, especially if the margins are not optimal. There is no indication in a Phyllodes tumor to do anything to the axilla, since these are sarcomatous lesions and they spread hematogenously and not to the axillary contents. They can also be treated in addition with chemotherapy, hormonal therapy, and radiation, although they're generally not necessary and not recommended since these are sarcomatous lesions, certainly not hormonal therapy. So here we see a patient with a Phyllodes tumor, and here we can see what they look like microscopically. They're stromal tumors, and here's a giant Phyllodes tumor as well. Excisional biopsy or lumpectomy is the last alternative for a palpable lesion. It's usually done for lesions that are either cosmetically or psychologically concerning to a patient. They feel a lump that's concerning to them. They want it surgically removed. Obviously, lumpectomy is also a breast cancer procedure, which we'll talk about in a few minutes. But this is really reserved, for example, for younger women who have a fibroadenoma that's bulging through the skin and it's causing them concern. They see it, they feel it. If you biopsied it and you know it's benign, you can reassure them. But if it's still concerning, then it's certainly legitimate to go ahead and remove. All right. Moving on to talking about high-risk patients. Which of the following diagnoses would lead you to do a confirmatory biopsy after a core biopsy? Intraductal papilloma, sclerosing adenosis, atypical ductal hyperplasia, cystic acrin metaplasia, or E, both A and C are correct. And the answer is both A and C are correct. D is just fibrocystic disease and doesn't really require anything more to be done. So, surgery for women at high risk for breast cancer. So first we have to define what high risk means. Is it a patient-dependent or independent factor? Is it a pathologic factor? How do you manage atypical core biopsies? What's concordant? What's discordant? We talked a little bit about that. The management of atypical ductal hyperplasia, atypical lobular hyperplasia, papilloma, radial scar, LCIS. How do you manage findings on biopsies for benign disease, i.e. after a breast reduction, which once or twice a year will get somebody who's had a breast reduction and they'll find either DCIS or LCIS or an incidental cancer in the removed specimen? And then what are the options for women at high risk? When is bilateral mastectomy or contralateral mastectomy indicated? So the first is, what are high-risk lesions? So this is the current recommendation to re-excise or remove the entire lesion if one of these is found on biopsy. DCIS, less so LCIS, atypical ductal and lobular hyperplasia, flat epithelial atypia, which is also called columnar cell hyperplasia, papillomas and papillary lesions, radial scars, and pseudoangiomatous stromal hyperplasia. Of these, the ones that everybody agrees should be re-excised include DCIS, atypical ductal hyperplasia, flat epithelial atypia, papillary lesions, and radial scars. Of those, everybody pretty much agrees. LCIS is controversial. ALH, most people would recommend, but it's not absolute. And pseudoangiomatous stromal hyperplasia has kind of fallen off that list and is no longer generally recommended as long as the biopsy was concordant and explains the lesion that's seen preoperatively. So, what's the risk reduction strategy for breast cancer? There are three categories: medications, surgery, and lifestyle changes. So the medications typically involve the use of anti-estrogen. The one that's FDA approved is tamoxifen. Tamoxifen is a competitive inhibitor of the estrogen receptor, and it reduces the risk of breast cancer by about 50%, i.e. it works predominantly on reducing the risk of estrogen receptor positive breast cancer, with the risks of taking tamoxifen, which are important, which include the increased risk of thrombosis, particularly venous thrombosis, and the increased risk of uterine cancer, which increases from about 1 in 1,000 to about 2 in 1,000. Raloxifene, which is a first cousin of tamoxifen, is not FDA approved for the reduction in breast cancer risk. The FDA approved use of raloxifene is to prevent osteoporosis. Raloxifene does reduce breast cancer risk, but it reduces it to a lesser extent than tamoxifen, but also has less side effects. Anastrozole, or Arimidex, is not FDA approved for reduction in breast cancer risk, but is being used it's one of the aromatase inhibitors, but it will only work in postmenopausal women. Remember that the aromatase inhibitors are only effective in women without circulating estrogen. Prophylactic mastectomy we'll talk about, as well as bilateral oophorectomy. And then, exercise, maintaining a healthy lifestyle, weight reduction, and reduction in fat can reduce breast cancer risk by about 1/3. So, there were 5 trials that compared tamoxifen or raloxifene versus placebo. There's roughly a 40% breast cancer reduction, 50% reduction in ER-positive cancers, but not surprisingly, no difference in ER-negative cancers. The endometrial cancer rate increased by 2.4% with tamoxifen, as did the risk of venous thromboembolic event. And raloxifene was about 3/4 as effective as tamoxifen, but with less side effects. Again, remember that raloxifene is not FDA approved to be used for the reduction in breast cancer. It's FDA approved for the treatment of osteoporosis. Surgical prophylaxis for breast cancer, Mayo Clinic study between 1960 and 1993, and that's important because this is the pre-BRCA screening era. So these women were not screened up front for BRCA mutation. This is a study of women whose control group was 403 sisters of the participants, women who were increased risk of breast cancer, All had bilateral prophylactic mastectomy. There was a 90% reduction in breast cancer risk, an 80 to 90% reduction in risk of death of breast cancer. 26 of the women were subsequently found to have a BRCA gene mutation, and no breast cancers in that group in a 13-year follow-up. In another study, 550 patients BRCA positive had bilateral oophorectomy, where they reduced ovarian cancer by 96% and they reduced breast cancer by 53%, similar to using tamoxifen, or the reduction in risk of ER-positive breast cancer. What are the Society of Surgical Oncology recommendations? Bilateral prophylactic mastectomy is one form of risk reduction, reduces breast cancer risk by 90%, should be done in the context of a multidisciplinary team, including surgeon, medical oncologist, pathologist, and genetic counselor, that you should review all of the risk reduction strategies, the use of medication, clinical trials, use of oophorectomy, and they should all be offered reconstruction. There have been some recent literature coming out about the use of prophylactic mastectomy, and that the feeling that it's being overused in the country, and that prophylactic mastectomy may not be necessary in as many cases as being used. You'll see that coming up from time to time in the different medical and lay journals. So breast cancer staging, stage 0 is carcinoma in situ, ductal or lobular. Stage 1, 1A and 1B, 1A, less than 2 centimeters, not spread outside the breast. 1B, no tumor in the breast, or the tumor is 2 centimeters or smaller, with smaller clusters of cancer cells, but not larger than 2 millimeter in the lymph node, T1N1 MIC. Remember, the number 0.2 millimeters, if the amount of cancer in the lymph node in the breast is less than 0.2 millimeters, it's not considered a positive node. So that's N0 MIC positive. So if you have less than 0.2 millimeters of cancer within the lymph node, that's not considered a pathologically positive lymph node. How they came up with that, I'm not certain. But if you see, just circulating IHC positive cells in the lymph node with no cluster greater than 0.2 millimeters, that's not considered a positive node, and it's noted as N0 parenthesis MIC positive. So, stage 2, 2A, T1N1 or T2N0. Stage 2B, T2N1 or T3N0. Pretty self-explanatory. Stage 3, T1 to 3, N2, N2 being 4 to 9 positive nodes, N1, 1 to 3 positive nodes, T3B, tumors ulcerated, inflammatory, or fixed to the chest wall, 3C, more than 10 axillary nodes, that's N3, or in the supraclavicular or internal mammary nodes, which used to be N1 but is no longer. So supraclavicular and axillary and supraclavicular nodes and internal mammary nodes are now considered N3, not M1. And then stage 4 obviously is any sign of metastatic disease.